Good morning. Um, so today we will go over, we're going to start a series of lectures. Now, after the hemodynamics lecture, which is more basic and more general, now we're really going to focus on the physiology of the heart itself as an organ over the next few lectures. I'm going to try my best to, to be slow and illustrate concepts because obviously, we're not face to face. We're unable to interact, you and I. Normally, it's much easier and much more interesting, really, for you because when we can interact by questions and answers, and you can ask me questions, and I can give you more clinical relevance to all these concepts. I think it makes it more fun for you. Uh, I think I even with everything, I would have rather be face to face with you, but I'm not the one to make decisions here, so let's proceed. So first, now we're going to focus on the heart itself as an organ. So first, basic things. The heart, not a big organ, 300 grams. And the heart consists of two pumps in series. Uh, the right side, left side, but of course, blood flows from right side to lungs, to left, to systemic circulation, and so on and so forth. The function of the heart, the sole function of the heart, is to pump a certain volume of blood per minute so that it can supply blood to all organs, including itself, including pumping blood to its own self, to the own myocardium. In general, roughly, the heart pumps 5 liters per minute of blood. Of course, this number can vary a lot physiologically and can vary a lot pathologically. In exercise, and a professional athlete, can increase their cardiac output to up to 20 liters per minute, maybe more. And in disease states, of course, it can drop to much lower than that. So therefore, anatomically, if you want to think anatomy, there are two sides of the heart providing a cardiac output to two circulations, the pulmonary circulation and the systemic circulation. Um, the distinction is important for two reasons. First of all, the pulmonary circulation in general is a much lower pressure circulation. The systemic circulation works at a much higher pressure. But also pathologically, you will learn later on that there are different disease states that can preferentially affect the pulmonary vasculature and spare the systemic vasculature, and vice versa. There are disease states that can mostly affect the systemic arteries, other disease states that can mostly affect the pulmonary arterioles and arteries. This is anatomically. Now, physiologically, if you follow blood flowing from in series, from left ventricle all the way back to the left ventricle, there are two different components of the circulation, and that is a high pressure component and a low pressure component. Meaning, the left ventricle in systole, when it contracts, generates a certain pressure, 120, 140, 150 millimeters of mercury, and therefore ejects a certain stroke volume of blood at this high pressure. So the LV in systole obviously generates a high pressure, and this high pressure is transmitted along with this stroke volume of blood that it ejects into the artery at high pressure. And that's why pressure in the arteries, in the aorta, in your carotid, in your femoral, in your popliteal, is almost the same, and it's 120, 130, 150 millimeters of mercury. All the way to the arterioles, so blood reaches the arterioles at the high pressure, and as we learned in the physiology lecture, the arterioles are the level at which there's a steep drop in pressure because there's such a high resistance to flow, because arterioles vasoconstrict, their radius drops, and we spoke about resistance and what that does, leading to a loss of pressure because there's dissipation of pressure and loss of pressure in the form of heat. So by the time blood reaches the capillaries, now you're in a very low pressure component of the circulation. Capillaries have a very low pressure. Blood then reaches the veins, low pressure. The right atrium, the right ventricle, low pressure, because the RV, even in systole, generates 20, 30 millimeters of mercury. That's still low pressure compared to the left ventricle. Then blood flows through the whole pulmonary circulation at a low pressure, reaches the left atrium, which also has a low pressure, and reaches the left ventricle in a relaxed state, in diastole, still at a low pressure, until the LV again contracts and we're back to square one. Now, therefore, the cardiac output is a measure of flow in liters per minute, and in normal conditions, the right ventricular cardiac output is equal to the left ventricular cardiac output. Whatever liters per minute cross the left heart have to be equal to the right heart. Why am I saying in normal conditions? Because, for example, in babies born with a certain hole in the heart, a hole between both ventricles and the ventricular septum, or a hole between both atria and the atrial septum, that changes because you have shunting of blood from one side to the other. So the RV stroke volume or the RV cardiac output might be different than the LV cardiac output. But in normal physiologic conditions, the cardiac output is the same. Now, cardiac output per minute is equal to the stroke volume, a single heartbeat volume, times the heart rate. Meaning, if your heart ejects 100 cc's of blood per beat and is beating 50 times per minute, then per minute it's ejecting 100 times 50. Very simple, very logical. And as we said, on average, it's 5 liters per minute. In the clinical setting, you will next year and forward, you will see that very often we use a measure called cardiac index, which is cardiac output divided by body surface area. And the normal would be anywhere between 2.5 and 4 liters per minute per meter square of body surface area. Why is that, and why do we use that? Because you cannot expect the same cardiac output to apply to a little old lady who's 90 years old and weighs 40 kilos, and Michael Jordan, okay, a huge athlete, very muscular, etc. So you have at times to average it to body size in order to especially in disease states, in order to target a certain cardiac output. You cannot target the same cardiac output in a young, huge athletic man and a tiny little old lady. So that's why, like a lot of things in medicine, like the way you dose chemotherapy in cancer, you dose it per meter square of body surface area. So that's what cardiac index is. Now, over the next half hour to 1 hour, we're going to discuss the cardiac cycle, which is the sequence of events that happen in one heartbeat when the heart functions as a pump. The phases of the cardiac cycle are as follows. So one cardiac cycle is a sequence of events, electrical and mechanical, that happen in one heartbeat. That's what we're going to dissect. Therefore, how long does a cardiac cycle take? Well, it varies. There's no real duration of a single cardiac cycle. For example, if your heart is beating at 60 times per minute, your cardiac cycle will be 1 second. Because if you have 60 heartbeats in 1 minute, each heartbeat takes 1 second. If your heart is beating at 120 beats per minute, each cardiac cycle is taking half a second because it's 60 divided by heart rate. Again, total common sense. And there are phases of the cardiac cycle. So we're going to dissect the cardiac cycle and divide it to phases. And these phases are limited by the opening and closing of different valves. And we're going to go through this. Now, the cardiac cycle, we're going to divide it to 4 phases. The first phase, and the reference point for the phases, by the way, is going to be the ventricle and what's happening in the ventricle. And the ventricle we will use here as a reference is the left ventricle. But remember, everything I say about the left ventricle applies about the right ventricle. Same thing. We're just going to use the left ventricle to illustrate these points. Remember that the RV, the right ventricle, is a mirror image with very minor variation. So phase 1 is the filling of the ventricle. So we call it ventricular inflow, meaning the mitral valve is open, the aortic valve is closed, the ventricle is relaxing, and it's filling with blood. Phase 2, the ventricle starts contracting, the mitral valve closes, but the aortic valve hasn't opened yet, and we're going to go through this in a bit. Phase 3 is when the ventricle is ejecting blood out into the aorta. And phase 4 is what we call isovolumic relaxation, meaning it has relaxed, the aortic valve has closed, but the mitral valve hasn't opened yet. Now, so therefore, this is a figure to illustrate all this. And basically, all this lecture can be summarized in this figure. If you understand this figure, you've understood the normal cardiac cycle. Let's focus on the upper part of this figure. The upper part of this figure is an illustration of pressures, and I wrote it for you on the right side. The upper part of this figure is pressures, and in blue, you're going to see the ventricular pressure, in red, the aortic pressure, and in yellow, orange, the left atrial pressure. This is what you're going to see. So, if you notice, the left ventricle can generate a lot of pressure. I didn't write numbers here, but the top of the peak systolic pressure of the ventricle could be whatever, 100, 150, 180 millimeters of mercury, or could be 100 millimeters of mercury. And the same thing would happen on the right side of the heart, except that on the right side of the heart, the pressures are lower for the same volume. We're going to go through this phase by phase. Here you see that what the arrow I illustrated for you would be systole. So systole would be from the point of ventricular contraction, meaning if you follow the blue line of the left ventricle, starting at a very low pressure, the moment the left ventricle starts contracting, pressure starts in a steep way increasing, and then the ventricle ejects blood until it relaxes. This is all systole. And the moment it relaxes and drops down, all of this, what you see in the blue, illustrated by the blue arrows on top here, would be diastole. If I look at the RV, the exact same thing is happening on the right side, except that pressures are much lower. Same volume, which is illustrated on the left side, and we're going to go through the volume in a bit, but at a much lower pressure. Now, as we said, the length of each cardiac cycle depends on your heart rate, but an important distinction to make is that systole, for example, if you have a heart rate of 75, the cycle length would be 60 over 75, which is 0.8 seconds for each heartbeat, for each cycle. As heart rate changes, so as heart rate increases and decreases, the cycle length will change. But effectively, if you look at systole and diastole, what changes really is the duration of diastole. So systole more or less has a fixed duration, but diastole is what varies. And you don't have to remember 300 and 500 milliseconds. No one's going to ask you about this. This is just an illustration that what varies is diastole. Why is that important? It's because there are certain disease states, valve diseases, pericardial diseases, where the heart and the filling of the left ventricle is impaired. So if you have a certain disease where the left ventricle is very stiff, is not compliant, or diseases you'll study later of the mitral valve where filling of the left ventricle is very impaired, is slow, the filling is very dependent on the length of diastole, meaning if diastole shortens, the filling of the LV is impaired. And therefore, these patients who really depend on that very poorly tolerate tachycardias because they need a slower heart rate. And I won't say more at this point, but just know that this is a very important concept, that as you make a patient more bradycardic, more slow, you are effectively increasing diastole, the duration of diastole, much more than you are affecting systole. So let's focus on phase one. Let's focus on phase one of the ventricular filling. And it starts exactly at the end of the green portion. Look at the right side, the right graph, the right picture. The green phase is isovolumic relaxation. We're going to get to this in the end, but start at the light purple phase. And if you look on top, the ventricular pressure, illustrated in blue, is dropping because now the ventricle is relaxing. And phase one is the ventricle in diastole, relaxing, where pressure drops so low that it drops below that of the left atrial pressure, which is illustrated in yellow at the upper part of the curve. And the moment pressure in the ventricle is below pressure in the left atrium, the mitral valve opens. This is what keeps a valve open or closed, is differences in pressure across that valve. Very simple. So therefore, the mitral valve opens, and the moment the mitral valve opens, the ventricle, which at this point is almost empty of blood, it's not fully empty, but it has emptied its blood in systole, and therefore the amount of blood in this ventricle is at a minimum, and this you see in the lower part of the curve. So the lower part of the curve, that black line, is ventricular pressure, left ventricular volume. So the lower part of the curve, in black, you see the left ventricular volume, which has reached its minimum, and at the very beginning of this phase, the mitral valve opens, and you have this quick, sudden gush of blood from left atrium to left ventricle, meaning the volume in the left ventricle starts very rapidly increasing. As you see, it's not a straight line. It has a very steep early portion. So very early filling of the ventricle. And therefore, during this phase, during phase one of the cardiac cycle, ventricular filling is not a homogeneous phase. You have a very early rapid filling, and then you have in the middle of this phase a period of what we call diastasis, meaning not much is happening. The ventricle has filled almost to full capacity, not to full capacity, but almost. The pressures in the left atrium and the left ventricle have equalized, as you see in the upper portion of the graph. And not much is happening until late in that phase. The left atrium contracts. Now, when the left atrium contracts, there's another bump in the left ventricular pressure, which in the lower portion of the curve you see at the right side, atrial systole, you see it. So the ventricle has almost reached full capacity in volume, and then you have another bump in volume, okay, and it fills. It doesn't go up and down. I corrected it. You see this little line. So you have another increase in left ventricular volume, and this is the contribution of the left atrial contraction. How much does it contribute? Around 20% of the LV stroke volume, but it can increase in exercise up to 40%. And there are disease states, you will study later, there are some arrhythmias called atrial fibrillation where the atrium doesn't contract at all, so you lose these 20%. But in normal conditions, this is what happens. So therefore, phase one is divided to an early rapid filling, a mid, very slow if no filling at all, and a late filling called the atrial contraction phase of the filling. And this would be illustrated here. So what do we do when we do echocardiograms and Doppler measurements of flow? We take the heart, which is, you see here in a cross section, and the upper portion in black and white is a real illustration from a real patient. There's the mitral valve, the left ventricle, and we measure the velocity, linear velocity by Doppler of blood flowing from the left atrium to the left ventricle. And how would this velocity look? It would look like this. So these are real measures from a real patient. You would see that if I just look at velocity, this is filling the velocity of blood crossing the mitral valve into the left ventricle. Early, which is E, you have an early wave of ventricular filling, E wave for early, where you have a rapid filling of blood into the left ventricle, followed by a deceleration, and then almost nothing, very little flow called diastasis, until the atrium contracts, And when the atrium contracts, you have another bump in the velocity of filling, and that's the late ventricular filling, or the A wave. Early, and then A for atrial contraction. Now, at the very end of phase 1 is when the ventricle has filled almost completely. As an example, 120 milliliters, as you look here at the graph. And the LV pressure is still on the low side. Still, the LV is still in diastole and is right about to contract. So that very last point in diastole, or in phase 1, right at the point when the LV now starts contracting, starts generating pressure, is what we call the end diastolic pressure, when you look at the upper portion, and I drew these for you, and the end diastolic volume. So LV end diastolic pressure and LV end diastolic volume. The LV end diastolic pressure is a very important concept because until this point, until this millisecond, this end diastolic pressure, the mitral valve is still open at this point and is about to close as the LV generates pressure. Because the mitral valve is still open at this point, this LV end diastolic pressure is reflected to the left atrium, is equal. If you look at the graphs in the upper portion of the graph, the blue and yellow graphs of left ventricle and left atrial pressure, they're equal. Meaning at this point, the left ventricular pressure is equal to the left atrial pressure because the mitral valve is open. Therefore, this pressure, the end diastolic pressure, is transmitted to the left atrium. Therefore, it's transmitted. It's a single cycle. It's a continuous column of liquid, of blood. Pressure is transmitted to the pulmonary vein, which come into the left atrium, and therefore is transmitted to the pulmonary capillaries. In other words, the patient feels the pulmonary capillary pressure is felt by the patient, and this pulmonary capillary pressure is effectively equal to the left ventricular end diastolic pressure. So why is it that this is a very important measure and a very important concept? It's because the left ventricular end diastolic pressure is felt by the patient, meaning if you have a certain disease state, an abnormal left ventricle, a failing left ventricle, etc., where the ventricle cannot accommodate, loses its compliance, for example, etc., and cannot accommodate volume without having a much higher pressure, this LV end diastolic pressure will lead to a much higher pulmonary capillary pressure, meaning the patient can be very dyspneic, very short of breath, or even worse, can be crashing, can be having pulmonary edema, and so on and so forth. Therefore, these measures at the end of diastole are very important, and this is how phase 2 starts. So what is phase 2? Phase 2 is contraction, which starts very suddenly. It is preceded by, on the EKG, when you study the EKG portion, the QRS, which is ventricular depolarization. So whatever happens electrically slightly precedes what happens mechanically. So electrically, on the ECG, you will see that there's electrically a wave of depolarization leading to ventricular contraction, and immediately the ventricle contracts. And the moment it contracts, the LV pressure, because the LV is a thick muscular structure, generates a lot of pressure. And it generates a lot of pressure, and you have a very sudden steep increase, the blue line on the upper portion of the graph, steep increase in LV pressure. The moment the ventricle starts contracting, its pressure rises above the left atrial pressure, and therefore the mitral valve closes. The mitral valve closes. So that's how phase 2 starts. Phase 2 is marked by the closure of the mitral valve. But as you see illustrated on the upper curve, there's a brief, phase 2 is a very brief phase. It's a phase where the ventricular pressure is increasing. It's higher than the LA pressure, so the mitral valve is closed, but it still hasn't reached aortic pressure. Remember, throughout this whole phase, aortic valve is closed because the aortic pressure is higher than the LV pressure. So the aortic valve is closed, and the LV hasn't reached the aortic pressure in order to be able to push the aortic valve open. And therefore, you have a steep rise in pressure, at a constant volume. Mitral is closed, aortic is closed, the ventricle is a confined chamber. There's no place for blood to leave. And therefore, if you look at the lower portion of the curve now, it's a straight line. The LV volume doesn't move, doesn't change. And that's why it's called isovolumic. No change in volume, steep rise in pressure, until, it's a very brief phase, the LV pressure in blue rises and reaches the aortic pressure. It's the aortic diastolic pressure at this point. And right as it kicks into it and gets over it is when the aortic valve opens. And this is when the aortic valve opens. So when the aortic valve opens is the start of phase 3, which is the ejection phase, which again I have dissected for you on the right side of the screen. So what happens in phase 3? The left ventricular pressure now has reached aortic pressure and is still rising, so it's rising slightly above it, but we're talking nothing, a millimeter of mercury, just above it enough to push the aortic valve open and start ejecting blood. So therefore, what happens in phase 3? The aortic valve opens, and the moment it opens, again, you have an early rapid ejection of blood into the aorta. So if you look at the lower portion of the graph, which is that of the volume in the LV, you're starting with a high volume, which is what the LV filled in diastole, and you have a very steep drop in volume because you have a rapid ejection of blood and loss of volume into the aorta until the LV has pretty much emptied what it has to empty. So it has a rapid early ejection phase, then a slower ejection because the LV is still contracting until you see that the aortic and LV pressure, so what drives the aortic pressure, what drives the aortic systolic pressure in red at the upper portion of the curve is the LV. So the left ventricular systolic pressure is what leads to an aortic systolic pressure. They're equal, they're the same. And then the ventricle starts relaxing, pressure starts dropping in the ventricle and the aorta with it, because at this point the aortic valve is open and they're almost like one chamber, until the LV pressure now starts steeply dropping in blue, and drops below that of the aortic pressure, and therefore the moment it drops below aortic pressure, the aortic valve shuts, closed. And when the aortic valve closes, this signals the end of phase 3. So therefore, let's say, for example, that the LV started with an end diastolic volume of 120 milliliters, ended with an LV end systolic. So at the end of this ejection phase, let's say the LV still has within it a certain volume, because the LV doesn't empty everything in it. This volume that's left in it is the end systolic volume. This is illustrated at the lower portion of the graph. What's left is the end systolic volume. The difference between end diastolic and end systolic is what has been ejected and is the stroke volume, which in this example would be 70 cc's, 70 mLs. Now, an important concept we're going to talk about a lot is whatever percent of the end diastolic volume has been ejected, meaning stroke volume over end diastolic volume, is what is called the ejection fraction. So ejection fraction is what percent of the LV end diastolic volume has been ejected, is stroke volume divided by LVED volume, and that is ejection fraction. Now, phase 4 is again a very brief phase, just like isovolumic contraction. It's the phase in which the left ventricle, if you look on top, it's the green phase. So the pressure in the LV has just dropped below the aortic pressure in red. Aortic valve has closed. If you look at the red line, which is the red graph of aortic pressure, that's what the dicrotic notch is. The moment the aortic valve closes and the aorta, which is a bit elastic, is recoiling on itself, it causes another slight bump in aortic pressure, called the dicrotic notch. And then the aortic pressure starts dropping, and this is how the aortic pressure is dropping to reach its own aortic diastolic pressure. 70, 80 millimeters of mercury, whatever, but way higher than the LV diastolic, obviously, because it has blood contained within it now, whereas the LV is empty and it's totally relaxing. And In blue, you see the steep drop in LV pressure. So as the LV relaxes, pressure falls quite steeply. But over these very few milliseconds, there's a phase, this phase, phase 4, in which the aortic valve is closed, but the mitral valve is still closed because the LV pressure still hasn't dropped low enough to reach the LA pressure, the left atrial pressure, until at the end of this phase, the ventricular pressure drops low enough to go below the left atrial pressure, which you see in yellow, and the mitral valve opens, and then we're back to phase 1 and to a rapid filling, and so on and so forth. Now, I mentioned earlier the QRS and the EKG. This is just a small figure to show you that everything we spoke of, every mechanical event, is preceded, very few milliseconds, but it's preceded by the electrical event that corresponds to it. Meaning, soon you will study the ECG, and in the ECG you will study that there's an electrical wave called the P wave that corresponds to atrial depolarization, and then another wave called the QRS, which corresponds to ventricular depolarization. This is just an illustration to show you that, for example, if you look at the whole ventricular contraction, the steep rise in ventricular pressure, it's preceded by the QRS. So the QRS is not in the middle of a ventricular systole. The QRS signals the start of ventricular systole. That's why there's a slight electromechanical delay for any action potential to be translated to a mechanical event. So the QRS is effectively the QRS, which is ventricular depolarization, and in the lower portion of this graph, effectively is the end of diastole, or signals the start of systole. And then you have all of systole that comes after it. And this is just a figure to illustrate this point. Now, these are pressure recordings that I got for you from one of our patients. So this is just a picture from our own cath lab, from one of my own patients, a picture that I took with my own cell phone, just to show you that everything, all these graphs I showed you are not voodoo. This is not theory. These are things we use every day. Because I know how it is in Med 1 and Med 2, you learn so many things, half of which you wonder, how the hell is this going to help me in the future? So this is just to show you that, at least in cardiology, this is all common sense, and all of these have clinical implications. The only difference is that I'm showing you here a graph on the left side of left ventricular pressure. This is a catheter sitting in the left ventricle. The pressures up and down look exactly like what I just showed you. And aortic pressure on the right side of the screen are not superimposed on them like the graph I just showed you, simply because we're using one catheter and we moved it from the left ventricle to the aorta. We could have put two, and then the figures would have looked exactly like the figure I showed you. And I drew a small white line, and I pointed to you where the LV and diastolic, how we measure in the clinical setting the LV and diastolic pressure. At the very end of diastole, right before the steep rise in left ventricular pressure, on the third beat, I drew for you a small white line connecting the LV EDP pressure all the way up to the EKG, to the QRS, because as I said, the QRS complex on the ECG is what signals the start of systole, or if you want, the end of diastole. And therefore, the pressure at that point is the pressure in the left ventricle at the very end of diastole. And these are concepts, again, we use a lot. Now, if we look at the aortic blood flow, okay, the aortic blood flow. So if I look at blood flow in the ejection phase into the aorta, so just like we did in the mitral valve earlier, if I can use a certain reference point in the ascending aorta, right above the aortic valve, and look at velocity of blood flow, and this is illustrated in the lower curve, the lower portion of the graph. You will see that blood flows in the aorta, of course, in phase 3, when the aortic valve is open. Otherwise, there is no blood flow. There is no forward blood flow. And the moment the aortic valve opens, you have a very steep rise of flow at a high velocity, and then a very steep drop in forward blood flow. Okay, very steep drop in forward blood flow until you hit the end of phase 3, and the aortic valve closes, and this is where you've hit phase 4, which is the green phase. All of this in the lower portion of the graph. And actually, if you look at aortic blood flow, you will see that in the isovolumic relaxation, meaning at the very end of the blood flow, in the green portion, when the aortic valve has just closed, you see that there's almost the velocity or flow in the aorta moves backwards. So there's a small drop as if blood is moving backwards and for a brief period of time, and then it equilibrates. And this slight backward drop corresponds to blood going back, not into the ventricle, because a normal aortic valve should be closed. So where is this blood moving backwards? It's moving into the coronaries, because the ostia of the coronaries are at the very bottom of the aorta. And when do they fill mostly? In diastole. So the moment diastole starts is when you have a bit of blood that leaves the aorta and moves into the coronaries, feeding the myocardium itself. Now, how about the atrial cycle? The atrial cycle. So everything we spoke of was the ventricular, what happens in the ventricle. And we spoke a bit of the left atrium. But if we want to now focus on the left atrium, the left atrial pressure is not a straight line. The right atrial pressure, same thing, because left atrial and right atrial pressures are almost the same, are not a straight line. Now, how do we measure right atrial pressure at least? The right atrial pressure is equal to the jugular venous pressure because they're connected. So you could look at this curve as an atrial pressure. You could look at this curve as a jugular venous pressure. It's the same thing. But what happens in the atrium? Of course, the atrium doesn't generate much pressure. So whatever pressure variation you're seeing here is a variation in very few millimeters of mercury. 5, 6, 7 millimeters of mercury, then down to 2 millimeters of mercury. Very little variation. But if we magnify these pressures, what happens in the atrium is the following. At the very end of phase 1, what did we say happens at the end of phase 1? So on the left side, look at the upper curve, left side, there's an atrial contraction. So the atrial contraction generates a bit of pressure. Still, it's a bit, 8, 9 millimeters of mercury, maybe less, because the atrium is a very thin structure. But this bump in atrial pressure we call the A wave. You see it, A on the left side. And then the pressure in the atrium starts dropping. And at this point, the ventricle has started to contract, the mitral valve closes, and when the mitral valve closes, it leads to a tiny bump in this descent in the atrial pressure called the C wave, or it's like a dicrotic notch just from closure of the aortic valve. And then in phase 3, which is that of when the ventricle is contracting, actually when the ventricle is contracting, the atria are relaxing, so you have a drop in atrial pressure. We call it the X descent. Very simple. The atrium has contracted, is relaxing, and this relaxation is called the X descent in pressure. And now, when the atrium is fully relaxed, and this is now the end of ventricular systole, the start of ventricular diastole, if anything, blood now starts coming into the atrium passively. If we're talking about the left atrium, blood is reaching the left atrium. I was just flowing into it from the pulmonary veins. And on the right side, blood is flowing into the right atrium from the vena cava, superior and inferior. And this blood flowing into the atrium will fill it, and therefore will lead to a certain increase in pressure just from passive filling, called the V wave. Why? Because it corresponds with ventricular systole. So you have, therefore, passive filling leading to a V wave. V waves standing for ventricle, mild increase in pressure, until when you reach the peak of this V wave, this is the end of phase 4, and again, beginning of phase 1 again, meaning the opening of the mitral valve, or the tricuspid valve on the right side. So the peak of the V wave corresponds to the opening of the mitral valve. The mitral valve opens, and what did we say happens? The moment the mitral valve happens, the atrium fills, empties its blood into the left ventricle. So the ventricle fills with blood, and therefore, because the atrium now is emptying itself, there's a drop in pressure again called the Y descent. And if you put them together in timing, you will see that this is how they are in timing. Lower part is the atrial cycle, upper part ventricular cycle, just to illustrate to you a little point that when the ventricle is in systole, pressure in the jugular vein, in the right atrium, in the left atrium is dropping. So the X descent is a drop in pressure which happens in ventricular systole because the mitral valve is closed, and this is not felt by the atria. That's just so you can see the timing of both in one graph. Again, this is an illustration of one of our patients looking at left ventricular pressure on the left, atrial pressure on the right, and you could superimpose them, and you would see that the systolic pressure of the left ventricle is exactly equal to the systolic pressure, the peak pressure in the aorta on the right side. So what if I showed you this graph where the LV peak systolic pressure is obviously way higher than the aortic pressure? And I asked you, what is the problem here? How come? They should be equal, because when the aortic valve is open, it's almost like one column of liquid. Why is it that pressure in the left ventricle is not fully transmitted to the pressure in the aorta? The answer is the aortic valve is not fully open. So you will soon study valvular heart disease, and you'll see that if the aortic valve is very stenosed, you have a gradient of pressure. So you have a loss of pressure, and we studied this in the hemodynamics lecture. You have a total loss of pressure between the left ventricle and the aorta. So as blood crosses the aortic valve, there's so much turbulence that you lose a lot of pressure. So that would be, if you have a much higher LV pressure than aortic pressure, that would be an example of a patient with aortic stenosis. This is illustrated right here. We have superimposed them for you. This is again one of our patients. You see the LV pressure. On the right side of the screen, you see that the LV systolic pressure is 190, whereas the aortic pressure superposed with it, the peak of it is 110, 111, and they're written, the values are written on the right side. So therefore, you have a difference of 80 millimeters of mercury between the LV and the left ventricular peak systolic and the aortic peak systolic. Why? Because this patient has severe critical aortic stenosis. What happens when we fix it and we put a new valve and then we keep measuring, you'll see that they become totally equal. Both now are 130. You see the difference? Now because we fixed this aortic valve, how we just implanted a new valve and we measured the pressure before we finished the procedure. That's the beauty of cardiology, because you see how logical it is. You see how you have a result right in front of you immediately. Now, before we end, we've been talking a lot about, closure of the mitral valve, closure of the aortic valve, and as we said, on the right side of the heart, same thing happens. Closure of the tricuspid, closure of the pulmonic. These closure of a valve makes a sound, and this is what heart sounds are. So the first heart sound, which we call S1, is the closure of the mitral and tricuspid valve, because they happen pretty much at the same time. And the second heart sound is closure of the aortic, and on the right side, the pulmonic valve. So S1, first heart sound, is closure of the atrioventricular valves, meaning mitral and tricuspid, and S2 is closure of the aortic and pulmonic. So that's why anytime you hear heart sounds, boom, 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 the first boom is S1, closure of the mitral, and the second is closure of the aortic/pulmonic. Rarely, there are states when you can hear a third heart sound, and that third heart sound is simply, what did we say, early on. You have an early rapid filling of the left ventricle. In certain states, this early ventricular filling can hit the myocardium, especially if it's a diseased myocardium, and make a certain sound. And at times, rarely, which could be normal or could be abnormal, you might hear a fourth heart sound called S4, which corresponds to the late filling of the LV. We won't speak much more about this now, because later on you'll study more these sounds. Thank you.